Okay, almost it's time to start this session. This session is a vulnerable plaque, imaging and physiology. I'm Hong from Severity Hospital. My co-moderator, as you know, Dr. Mintz. Actually, he's my mentor since the 1998. We have several panelists, Dr. Akasaka, Dr. Riquelme, and Professor Jang from Mass General, and Dr. Kubo from Japan, Dr. Lin, Dr. Matsuo, and Dr. Nakara Pillai, and Dr. Sadamatsu. This session, there is 7 presentation. I will introduce the first 3 topic, and we will have a discussion time at the end of the first 5 presentation. Okay, first topic is defining lesion severity by angiography, physiology by IVUS. The presenter is Dr. Ahn.
Thank you, Dr. Hong. I'm Jung-Min Ahn from Assam Medical Center. My topic is defining lesion severity. I think the determination of coronary stenosis severity to decide on the coronary revascularization should be evaluated from the perspective of myocardial perfusion. And it is necessary to demonstrate that reduced myocardial perfusion is due to coronary stenosis. Actually, we can define the objective ischemia. This patient have a chest pain and non-invasive functional study. Positive, yes, objectively the ischemia. But we have to get another connection between the ischemia plus coronary stenosis. So I think we can get such kind of idea from the fractional flow reserve. We measure the FFR. This is and FFR is lower. We can say that reduced coronary blood flow is related with this specific stenosis. This is the idea of fractional flow reserve. In addition, conventional cutoff value was the 0.75. Recent cutoff value is 0.80 based on our registry. I show that regarding the cardiac death MI TVR, including the TVR, cutoff value was 0.79, supporting the contemporary cutoff value. Regarding the hard endpoint cardiac death and MI, the cutoff value is lower than the contemporary cutoff value, 0.64 something. This is very similar to the mean FFR value of a FAME2 trial. So in addition, using the pressure wire pullback, then you can see the physiologic anatomy of a coronary artery stenosis with a single number. For example, FFR 0.80 is FFR 0.80. And pressure pullback, you can see the diffuse, focal, or mixed stenosis. I think this is very simple. The beauty of FFR is you can describe the one coronary artery stenosis status using the single number. So how about the coronary angiogram? 3 or 4 stenosis angiographically, and FFR different. Sometimes the severe stenosis, FFR is lower, but sometimes FFR is looking very severe, but FFR is high. What is the origination of the concept of significant angiographic stenosis, more than 50% from the Dr. Gould animal study? I tried to find the other study to support the diameter stenosis to 50% is the significant. I cannot find it. So anyway, based on the animal study, without atherosclerosis, diameter stenosis more than 50% associated with the reduced maximal flow, almost 80% associated with the reduced resting flow. So Dr. Gould said that what is the critical stenosis? Constriction sufficient to prevent the increase in flow over resting value in response to increased myocardial oxygen demand. So actually 80% is a critical stenosis. So this was also demonstrated by some nuclear study. So more than 70% percentage diameter stenosis showed that failed to increase the blood flow even after the maximum hyperemia. So, however, can you guess in a real daily practice, this is we made a stenosis model and contrast. This is 50% diameter stenosis. This is only 70%. Yeah, critical stenosis in your cath lab, this is actually critical stenosis. So usually in our practice, the angiographic diameter stenosis is overestimation. So in addition, the coronary angiogram is a 2D plane imaging, so inaccurate inherently. In addition, many surface, even though similar diameter stenosis, according to the different surface or something small change in the surface or rupture, something like that, the change in the hemodynamics. So that's why angiogram is inaccurate. In addition, coronary physiology determined by the also myocardial amount of myocardial supplying myocardium. So diameter stenosis is not enough. After crossover, very tight stenosis, but we can guess the negative FFR. You also well demonstrated. So many visual functional mismatch based on the angiogram between the FFR. So in the FAME trial, the anatomically triple vessel disease, only 14% of lesions have truly triple vessel disease, and two vessel disease, only 43% is two vessel disease. We also evaluated the visual functional mismatch, non-left main and left main, large of mismatch between the coronary angiographic diameter stenosis and FFR. Particularly left main, diffuse looking disease, but angiographically diameter stenosis is not severe because of diffuse disease. But looking very tight, diameter stenosis is very tight, but when you measure the FFR, left is positive, right is negative because of the diffuse nature of coronary atherosclerosis. Inside the lumen is very big. So this is a common phenomenon of left main diffuse stenosis. Then how about the decision making and outcomes? If you use the diameter stenosis compared with the FFR, the angiographic stenosis treated more. So less treatment by the FFR. In addition, based on the FAME trial, in our registry data, after we used the routine FFR evaluation, clinical endpoint reduced. What caused the reduced? What component reduced? Mostly peri-procedural MI, late repeat intervention. So reduce number of stent, avoid unnecessary PCI, and subsequent decrease of peri-procedural MI, PCI-related complication, and repeat intervention. Even 2 years ago, last year, the random trial published that no difference between the angio-guided FFR-guided PCI in several clinical situations, even though consistently stent number decreased. So future trials show that increased the group of medical treatment. So another mismatch is the IVUS and FFR. Meta-analysis show that the best minimal lumen area to predict the FFR less than 0.80 was look between the 2.3 or 4.0, even though the diagnostic accuracy is very limited. So we published, previously we published that even though the very small, the IVUS minimal lumen area, the 30% of lesions, FFR is 0.80, because the IVUS is just a single cut of coronary artery. So Dr. Gang make effort to improve the accuracy of IVUS, determine the parameters using some softwares. But even though the diagnostic accuracy is very limited, how about the decision makings? One registry showed that Dr. Nam's registry showed that the FFR-guided PCI, IVUS-guided PCI showed that no difference regarding outcome, but IVUS-guided PCI increased PCI performance. Similar concept was applied in the randomized trial, flavor trial, IVUS versus FFR-guided PCI. IVUS criteria was less than 3 square millimeters, 3 to 4 square millimeters with a large plaque burden. 2-year clinical outcome, no difference, but the IVUS-guided arms increased the number of PCI. So this is my thought. Yes, we have to think about the myocardial perfusion and specific to the stenosis, In addition, anatomical decision-making, diameter stenosis or IVUS increases the risk of unnecessary PCI. Thank you for your attention.
Next topic is cardiac OCT, 20 years of bench to the bedside. Professor Jang, he will present this topic. I would like to allow more time because the 20 years the experience summarized only 7 minutes is very, very unfair. So please speak without the limitation of the time.
Thank you so much. Actually, it's not 20 years, it's 25 years.
Just read it in the...
So this is my disclosure. So much of what I'm going to say today is nicely summarized in these 2 upcoming publications. So this is history of OCT. It was developed by Professor Jim Fujimoto at Massachusetts Institute of Technology, 1992. 6 years later, 2 scientists from Jim's lab, Dr. Buma and Tierney, came to Mass General, and 3 of us formed an MGH OCT group. And it took 3-4 years to finish histology validation study, which is a critical step. And actually, first in-man study using the prototype catheter and prototype machine was right here at Asa Medical Center. It was done 2000, and the first publication was 2002. So this is a histology validation study. This study demonstrates that different components of plaque, fibrous, calcific, and lipid can be identified with OCT with accuracy of 0.85 or higher. And this is the first human study that replicates, actually, Dr. Vermani's histology report, fibrous cap thickness, the threshold of 65. So if you look at the prevalence of TICVA, was 72 acute MI, 50% ACS, and 20% in stable angina. So with the 7 minutes, which I thought I would have, I decided to focus on 2. Vascular biology research, that's the lab my lab has been focusing on. And then I'm going to just introduce recent advances using OCT. So vascular biology, I'm going to just touch upon these 4 entities. So the theme of our lab past 20 years has been atherosclerosis is a panvascular process with local destabilization. And plaque erosion is something that our group has been interested past at least 12, 14 years. Healed plaque, which is relatively new concept. So atherosclerosis is continuous plaque destabilization and healing, leading to rapid progression of atherosclerosis. And this new layer of healed plaque or organized thrombus, you can detect with OCT. So each layer has different optical density. And calcified plaque, that's something that I have worked with Aloke Fin. And we introduced, there are 3 distinct subtypes of calcified plaque at the culprit lesion of patients with ACS. So this is the, I'm going to show 1, maybe max up to 4 slides for each entity. So we look at the plaque phenotype of non-culprit plaque and compare phenotype between patients presented with ACS or non-ACS. The reason why I said non-ACS is a stable angina and positive stress test. So if you just look at the right side, thin cap fibroathyroma, in the non-culprit region, the prevalence was 44 versus 6.9%, depending on clinical presentation. So patients presented with ACS, they have panvascular inflammation, high level of vascular inflammation, compared to someone who came in with positive stress test or stable angina, who has much lower level of vascular inflammation. So this is plaque erosion, no-brainer. If you look at, calcified plaque is relatively rare, and I will come back to this. There are 3 distinct morphologic characteristics of plaque erosion compared to plaque rupture. Number 1, vascular integrity is much better preserved. Number 2, the true lumen is in general much larger in erosion compared to rupture. This is true lumen. And this granular structure, these are platelets. So just remember 3 distinct characteristics. So we did the proof of concept prospective study. It was a single center study, roughly 500 patients. Primary endpoint was the more than 50% reduction of thrombus volume without stenting, but with depth. So the red dots below this 50% line met the primary endpoint. So 85% of total population met the primary endpoint, means more than 50% reduction of thrombus volume after 1 month treatment of depth. Remarkably, 40% of total population, they had no residual stenosis, no residual thrombus after 1 month treatment with depth. So this is one example, 65-year-old man, anterior MI. This is during acute phase. This granular structure, these are all platelets. After 1 month treatment with aspirin ticagrelor, this is what you had. Minimal flow area increased from 2.4 to 4.0. So when you see a vessel like this, even interventionalist like Dr. Aloke, you are not going to stand this. So the second concept is healed plaque. As I mentioned, plaque progression, 75% of cases, is plaque destabilization healing. Mural thrombus which will be organized, leading to rapid progression. This organized thrombus will create these different layers with different optical density that you can see at the culprit lesion or even non-culprit lesion, both after rupture or erosion. So Francesco Fracassi looked at the features of those with layered plaque or non-layered plaque in patients presented with ACS. Number one, the prevalence of layered plaque in patients presented with ACS was 28%. And those with layered plaque or healed plaque had high features of vulnerability or vascular inflammation. First, high risk, hyperlipidemia, diabetes, previous MI, angiographically more complex, more plaque burden, OCT characteristics of plaque vulnerability. Michele Russo looked at stable angina population and saw same thing, same pattern, increased vascular inflammation, vulnerability. Depending on clinical presentation, the implication, the significance of healed plaque is totally different. So this is what I concluded. Presence of healed plaque at the culprit lesion indicate different atherosclerotic background depending on clinical presentation. ACS plaque disruption with increased thrombogenicity, local systemic, that outweighs endogenous antithrombotic defense mechanism. Whereas the stable angina, patients should have robust antithrombotic endogenous mechanism. Plaque disruption will lead to thrombus formation, but not occlusive. This endogenous thrombolytic system will limit that in a silent manner. So next is calcified plaque. I still don't understand why only calcified nodule has been reported. Maybe Aloke can explain to me. But when we look at in vivo patients with ACS, we look at the culprit lesion, and we found these 3 distinct types of calcified plaque. Eruptive calcified nodule, that's ruptured nodules, and then superficial calcific plate. You don't see any nodules here, and then a rare type is calcified protrusion. This eruptive calcified nodule is most frequently found in mid-RCA, where the torsion is maximum and associated with red thrombus, whereas superficial calcific plate, which is the most common type, was most frequently found in mid-LAD and platelet-rich thrombus. The features frequently seen after plaque erosion. So recent advances, just quick 1 or 2 slides. I'm going to cover biomarkers, gut microbiome, proteomics, and deep learning. These are the product of pandemic. So we have identified biomarkers associated with the unfavorable plaque phenotype. So all this, creatinine, fibrinogen, TNF-alpha, IL-6. We had a comprehensive battery of biomarkers. And we have also identified biomarkers associated with favorable plaque phenotype. And when we created this model A and B, AUC is 0.925 or 0.947. Microbiota, we try to correlate a gut microbacteria with plaque phenotype. So we have identified using linear discriminatory analysis 10 bacteria were associated with unfavorable plaque phenotype and 2 bacteria associated with favorable plaque phenotype. Using cladogram, we have demonstrated that there was a lineage associated with ACS. This is even more complex. This is a combination of biomarkers, OCT, IVUS, and gut microbiome. And the result is this: we have identified specific bacteria associated with vulnerable plaque phenotype. We also have identified bacteria associated with favorable plaque phenotype. Now, proteomics, not yet published, but we have identified certain proteins associated with high-risk plaque phenotype. I cannot disclose all the results, but clearly there was association. And finally, even for people trained and familiar with OCT interpretation, plaque erosion is not that simple. So we have devised a new algorithm. It's called transformer rather than CNN, convolutional neural network. The main difference between CNN and transformer is CNN, you use one frame, like chest X-ray, to make a diagnosis, whereas transformer is a product of natural language processing. When you hear someone speaking, you don't just pick up one word. You have to know pre and post. That's what transformer does. So we integrated frames before and after culprit lesion, put them together, and made a diagnosis. And external validation set increased the AUC from 0.84 to 0.905. So this is a summary. In vivo characterization of plaque phenotype has become possible with the introduction of OCT. ACS is a pan-vascular inflammatory process with local destabilization. Plaque erosion is responsible for 25 to 40% of ACS. Conservative management of patients with ACS caused by plaque erosion with antithrombotic therapy may be an option. Healed plaque at the culprit lesion in ACS patient indicate high level of pan-vascular inflammation vulnerability. Healed plaque in stable angina is likely the sign of repetitive silent disruptions that finally reach the threshold that will cause supply-demand imbalance. Distinct subtypes of calcified plaques has been identified, and biomarkers specific for high-risk plaque, gut microbacteria, and proteins associated with certain plaque phenotype have been all identified. And a deep learning model called Transformer has been devised to enhance the diagnosis of plaque erosion. And I didn't do all this work. These are the people who did real work, all the fellows, 40 so far. And we got together in July to celebrate the product of our collaboration. Thank you so much.
Excellent, great. Next topic is the vulnerable plaque. What is it? Pathological perspective.
Great.
Dr. Finn, Aloke.
Okay, thank you so much for the nice introduction. Nice to go right after Ik, who I worked with many years ago at MGH when I was a fellow there. Here's my diagnosis. This paper was written many years ago when I was a fellow at MGH with Ik. We had done the history of vulnerable plaque and understood some of the history of how long we've been searching for the vulnerable plaque and how long it's taken to get us to where we are. It really starts in 1844 when the Danish artist Thorvaldsen had described the first episode or description of plaque rupture, and then really continues into the 2000s when we've made even more inroads into understanding vulnerable plaque. I would recommend this paper not as a way of selfless promotion, but as a way of understanding the history of what has happened in the vulnerable plaque field over many, many years. So I was asked to talk about the pathology of vulnerable plaque. So Ik did point this out, which is that in order to understand vulnerable plaque, you have to understand the causes of acute coronary thrombosis and the underlying morphologies responsible for it. As we all know, plaque rupture is the most well-recognized, and I'll explain a little bit more about it. But plaque erosion is actually a fairly common cause of luminal thrombus formation and acute MI, and then lesser known is calcified nodule, as Ik referenced. And this goes over the detailed morphology of each of those plaque phenotypes. Plaque rupture, you all know, probably responsible for 45 to 55% of thrombi and sudden coronary death. Males greater than females, usually eccentric or concentric, and there's some macrophages inflammation in the cap itself. Ik has described this very well, not in just pathology, but in OCT as well, with some very good work. Plaque erosion is actually a lesser well-known entity, but responsible for a fair number of thrombi and sudden coronary death, 35 to 40%, consistent with what's been seen by OCT. Equal in males and females, younger, and this is a lesser inflammation-rich plaque, usually a fibroatheroma or pathological inner thickening that overlies an eroded endothelial layer. There's really no rupture in this type of plaque. And then calcified nodule, as he mentioned, is more of an older patient disease, calcified plates or nodules of calcium that really erode into the lumen, causing thrombosis. Now, prevention treatment paradigms, this is something where we don't really understand a lot, believe it or not, at this point. If you think about it, we use lipid lowering as our primary method to decrease coronary artery disease events. But we really don't know how we're modifying plaques exactly. Are we preventing ruptures, erosions, calcified nodules? What are we doing? I think it's most likely that we prevent ruptures from occurring. Are we really preventing erosions or calcified nodules? That's something we really have to understand better. The progressive and non-progressive coronary plaques are shown here, and really what I wanted to show is pathological intimal thickening is the first stage of atherosclerosis, with lipid pool, with inflammation, and some muscle cell loss with extracellular matrix. And then we get more progressive plaques, fibroatheroma, which is more cell death, and necrotic core, and then we get the thin cap fibroatheroma, which is an even more advanced form of the fibroatheroma with a thin cap. And the paradigm of vulnerable plaque is really a plaque rupture paradigm. When we talk about vulnerable plaque, right now all we really know is what occurs within the plaque rupture paradigm. And we believe that the thin cap fibroatheroma is the precursor to plaque rupture. Now, why do we believe that? Only because of one reason. When you find these plaques at autopsy, they resemble ruptures in every single way, except they haven't ruptured yet. There's a thin fibrous cap, there's a large necrotic core, there's a cap infiltrated by macrophages with cap composition of type 1 collagen, and we really do think that this goes on to cause plaque rupture, but we have really no in vivo evidence clearly linking these two phenomena. We do know that as you lower LDL in patients, and you have, this is an OCT study that was done with different amounts of LDL in different patient populations, you can see that you change plaque characteristics. If you look at high LDL patients, they generally have lower fibrous cap thickness, more evidence of thin cap fibroatheromas, and more evidence of plaque ruptures, whereas patients with lower LDLs really have the opposite. They have thicker fibrous caps and much less thin cap fibroatheroma. This is probably evidence per se that really lipid lowering affects the plaque modulation of thin cap fibroatheroma, or the development of thin cap fibroatheroma and rupture. And we certainly know that lipid lowering is very effective preventing events. This is just a slide showing all the different lipid lowering trials and the relationship between the LDL and the events, which we certainly know is closely linked. This is a study from OCT looking at non-culprit plaques that went on to rupture and cause events. And you can see that those non-culprit plaques, when you look at the presence of lipid-rich plaque, lipid arc greater than 180, fibrous cap thickness less than 65, in both, you can see majority of plaques that went on to rupture or cause events had those characteristics of a lot of lipid and looked like thin cap fibroatheroma. So we do have some aspects of the paradigm correct. Now, if we look at the PROSPECT trial, and I could go on with other trials as well, we know that there are certain factors or features of IVUS that link to future risk of events. The problem, of course, is that in this particular study, these factors were linked to increased risk of events, but in 88.2% of patients with similar plaques, they did not go on to have a MACE event. So, the actual on a per patient basis, accuracy of this is not high. And that's one of the problems with the vulnerable plaque paradigm. We really don't know who's going to have the event. Mechanism of contributing to rapid plaque progression, you can see here, I've shown you that there's a positive remodeling effect up to a certain percent stenosis, and then we start to get negative remodeling with inflammation and more intraplaque hemorrhage, neovascularization. I think the contributing factors to negative remodeling are presence of healed ruptures that Ik mentioned, as well as intraplaque hemorrhage. Now, I just want to go on briefly and talk about a few other plaque phenotypes. Plaque erosion, you know that plaque erosion is responsible for a fair number of events, and you can see here typical plaque erosion with fibroatheroma, eroded endothelial cells, and a fibrin and platelet-rich thrombus overlying that erosion. And we know that plaque erosions are really seen in patients who are younger, who are smokers, and don't have as high a cholesterol level. Total cholesterol is much lower in plaque erosions. And really a disease of younger patients. You can see in women and in men, incidence was much higher in younger individuals. We really don't know the risk factors for plaque erosion. So we talk about vulnerable plaque. We don't know the vulnerable plaque that underlies plaque erosion and which one of those fibroatheromas or animal thickenings will go on to erode. That's a big mystery and a missing link. Now, calcified nodules, Ik mentioned, so I'm just going to briefly talk about this, pathophysiology. As he mentioned, you can see calcified nodules in the RCA. Mostly, there's some in the left main LAD circumflex, but mainly seen in the RCA, in the mid and proximal regions of the RCA. And we did a study recently. This is showing you the X-ray of a patient that died of a plaque of a calcified nodule. And what I'm showing you here is the D is the eroded site, and we've looked at the flanking areas upstream and downstream of that plaque. And you can see the pathology here. The D is that you can see all those nodules of calcium on the Movat stain in the blue eroding into the lumen, causing thrombus. This is really what calcified nodule is. And you can see when we looked at the types of calcification associated with calcified nodule, what we showed is that at the proximal and distal regions, there was sheet calcification, and at the culprit site, there was much less sheet calcification. So what we really think happens, and this is the example, is there are sites at sites of high torsion between areas of calcified plates. There's a necrotic core which is calcified, and then undergoes a lot of torsion between these calcified plates, causing the calcium to essentially get nodular and erode into the lumen. And that's the mechanism we think that causes calcified nodule. And here are the mechanisms shown in this paper. I'm not going to go over that. The other thing I wanted to show you briefly was that, you know, we have GWAS now. We have genetics that underlie CAD. And whether genetics can help us predict vulnerable plaques is another factor which has not really closely been looked at. We can use polygenic risk scores. Now, polygenic risk scores are basically the estimated effect of a number of genetic variants on an individual's phenotype, and we can weight each of those variants by the number of the actual weight in terms of effect size of the individual variants. And if we calculate all of the ones that an individual has, that would be called a polygenic risk score. And you can see here that if you look at our database of vulnerable plaques and you see how many people had thin cap fibroatheromas, it turns out the polygenic risk score was much higher in those that had vulnerable plaques than those who did not have vulnerable plaques. And so you can see it can be used as a predictive way to try to identify who's going to harbor vulnerable plaques. So I think I've shown you some insights into pathology of plaques. The vulnerable plaque is likely a precursor or lesion of rupture. I think lipid metabolism inflammation play an important role. Intraplaque hemorrhages, I didn't discuss it, really are important for enlarged necrotic core. The risk factors for plaque erosion remain poorly understood, as well as for calcified nodule, but I think we are beginning to understand more about those. Genetic risk scores will play an important role in primary prevention in the future and may help decrease the incidence of vulnerable plaques through early access to medical therapy. So with that, thank you for your attention.
So I'd now like to ask Professor Akasaka to talk about vulnerable plaque identification by OCT and NIRS-IVUS.
Thank you for kind introduction. This is disclosure. As Dr. Finn said, this is the three major causes of ACS, and most of ACS may occur from coronary thrombosis based on plaque rupture, erosion, calcified nodule, and OCT allows us to differentiate them accurately, except for a definite and probable erosion. Although NIRS-IVUS may provide us the amount of lipid component, there are no data for differentiating them. And this is a classification algorithm in ACS by OCT proposed by Dr. Ik-Kyung's group. And there are 3 major causes and others. There are some other causes: intraplaque hemorrhage, spontaneous coronary dissection, or healed plaques, as already is demonstrated. The limitation of this classification by OCT is the OCT erosion, because if there are big thrombs, underlying plaque condition cannot be difficult to identify. So in their report, this is a representative case of definite OCT erosion and irregular lumen surface with attached mural thrombus overlying fibrous plaque can be identified. And also, this is a representative case of probable OCT erosion. Underlying plaque morphology is not well visualized due to the presence of residual red thrombus with signal attenuation without any detectable rupture. And this is an OCT findings of 3 underlying plaque characteristics reported at the same time. And the thin cap fibroadenoma is much higher in plaque rupture, and also the red thrombus is much higher in plaque rupture, and lipid-rich plaque is significantly higher. And in plaque erosion, lipid-rich plaque is significantly lower, as shown in this slide. And similar report, you can identify several reports, and this is another one of them. Erosion is, the lipid plaque is significantly lower, and TICFA is significantly lower, as I already explained. So based on these data, even if the plaque erosion demonstrates a lipid plaque, the total lipid content might be a little bit lower compared with a lipid-rich plaque with plaque rupture. So today I would like to demonstrate the ability of NIRS-IVUS to differentiate among plaque rupture, erosion, and calcified nodule in AMI, and to predict future event in vulnerable plaque. And this is the original purpose to investigate the ability of NIRS-IVUS to differentiate among causes of an AMI, as I already said. And 244 culprit lesion was performed, the OCT and NIRS-IVUS before PCI, and the differentiation may be based on the previous report by Ik-Kyung's group. And we divided this culprit lesion into 2 cohorts. One is 156 for develop the NIRS-IVUS classification algorithm for diagnose the cause of ACS, and also based on these classification, we did the validation cohort, using a validation cohort, as shown in this slide. This is a representative case of OCT plaque rupture. You can clearly identify the plaque rupture by OCT, and IVUS also revealed the plaque cavity. It might be, based on the resolution, it might be very difficult compared with IVUS, but you can identify. And NIRS identified large lipid content in the culprit lesion, demonstrated max LCBI more than 800. And this is a case of plaque erosion. OCT demonstrated plaque erosion showing the thrombus overlying an intact fibrous cap, and IVUS revealed the absence of plaque cavity, and NIRS identified a small amount of lipid content in the culprit lesion. Max LCBI is less than 100. And also this is OCT calcified nodule, and showing protruding in calcium with thrombi and near circumferential calcium by OCT, and similar findings can be identified by IVUS, and NIRS identify moderate lipid content in the culprit lesion. Max LCBI is 300. And this is the clinical characteristics in plaque erosion. The younger patient much frequent. And this is the angiographic findings. As you speculate, heavy calcification is very common in calcified nodule. And this is an IVUS finding at the MLS site. We can identify even IVUS rupture. And also the burden is significantly smaller in plaque erosion, and positive remodeling is higher in plaque rupture. And this is an NIRS data in OCT plaque and erosion and calcified nodule. NIRS demonstrate the max LCBI is significantly lower max LCBI in plaque erosion compared with rupture and calcified nodule. And this is an ROC curve of max LCBI for differentiating between OCT plaque rupture and OCT plaque erosion, and with sensitivity of 92 and specificity 97, cutoff value of 426. And using this algorithm, we can clearly differentiate we can recommend this algorithm. If you identify the convex calcium by IVUS, NIRS IVUS, this is a calcified nodule. If you identify the plaque rupture, cavity, it should be a definite plaque rupture. If you cannot identify any plaque cavity by IVUS, if max LCBI is more than 400, around 400, it might be a probable plaque rupture. And if it is less than 420, the definite plaque erosion. And this is a validation cohort data using such a classification algorithm, and we can clearly identify the plaque calcified nodule, definite plaque rupture, probable plaque rupture, and definite plaque erosion. And with this algorithm ability of NIRS IVUS for identifying the rupture, erosion, and calcified nodule with high predictive value, with high positive predictive value and negative predictive value, as shown in this slide. And as you know very well, LRP study demonstrates a high predictive value of the future event if the max LCBI is more than 400. And also this is already demonstrated by Dr. Finn. This is our data published by Dr. Kubo, right? If the OCT demonstrates lipid-rich plaque and ThinCap fibroadenoma, the prognosis is poor. Therefore, combined modality should be ideal. This is already proposed, reported in 2013, right? OCT demonstrates similar findings, but right-hand side demonstrates lipid-rich plaque, so we can differentiate. And recently developed deep OCT with NIRS by the spectral wave company. We can obtain the much deeper image by OCT with NIRS, as shown in this slide. You can identify the lipid here, and also this is a plaque rupture, or 360-degree. Yes, lipid can be identified. So this is my take-home message. It might be difficult to differentiate clearly between probable erosion and plaque rupture by OCT alone because of the huge red thrombus with signal attenuation on the culprit side. NIRS IVUS may allow us to identify definite plaque erosion from probable erosion and or rupture by evaluating max LCBI in addition to the findings of plaque cavity and convex calcium. And combined use of OCT and NIRS may provide us to differentiate those more accurately compared with a separate use of each modality. And NIRS OCT might be ideal modality to identify the mechanism of ACS caused by rupture, erosion, and calcified nodule with ease and accurate. Thank you very much for your kind attention.
So our next presentation by Akiko Mehara, reclassification of vulnerable plaque, including intraplaque, hemorrhage, fissure, healed plaque, and more.
Thank you. I think there is some overlap, sorry.
I know.
So this is a healed plaque by the pathologist. You see the large necrotic core, and on the top of the fibrous cap, there is a different layer of the smooth muscle cell and fibrous tissue. That's the healed plaque. By OCT, we can identify this very accurately. Typically, that's something a little bit lower intensity compared to the underlying plaque. And also, the pathologists tell us this is the most important mechanism of the increase of the plaque progression. And we did the study compared to the baseline and follow-up to see the natural history of the plaque progression. This including 127 non-culprit lesions. And out of those, 24 non-culprit lesions had significant progression at 8 months. And out of those, 40% of the cases, lesion having the newly appeared healed plaque on top of the ruptured segment or non-ruptured segment. So that really tells us the plaque, healed plaque is a progression of the disease. This is a study showing the ACS culprit having the healed plaque together with the underlying plaque rupture, etc. So having the healed plaque together with the regular culprit underlying plaque, having more likely non-STEMI presentation or more likely underlying cause was plaque rupture. This is a single center study including 823 patients over the 7 years. And I think this is very specific cohort. They're picking up 3 very important different people. Number 1, recurrent ACS, having the 3 times MI in the life or 4 times ACS with 1 MI, which is really looks like a vulnerable patient. The next 37 patient is prior MI, and after 3 years, they are stable. The next patient is in life, no MI at all, truly stable coronary artery disease patient. And they look into the non-culprit lesion, and then only the recurrent ACS patient having less healed plaque compared to the other. Although I think this has to be very carefully read because the amount of the patient is very little, and that represents only the 4% of the entire cohort. But something very specific patient having some future to saying what meaning of the healed plaque. And in terms of the event, they include only the cardiac death and ACS-related event. If they include only the ACS-related event, recurrent ACS patient having more such event. And then talking the what is the underlying plaque associated with such event, not having the healed plaque is more likely associated future MI or ACS. On top of the regular, like the TICFR or other findings. On the other hand, we did this study. So when we include all patients consecutively, and then not only the ACS, but also any event which causing the ischemic event, we see the healed plaque is actually more likely future event compared to without. So we have to reconcile somehow two different aspects. So to summarize, having the healed plaque is really the marker of the future atherosclerosis progression. Not having the healed plaque is probably the marker of the future ACS event. That's probably yes. Let's talking the intraplaque hemorrhage. That's also very interesting, and many times, not many times, long time ago, the pathologist tells us having the intraplaque hemorrhage was associated with atherosclerosis progression. And other interesting point of this story was they specify erythrocyte membrane had the greatest amount of the free cholesterol. Therefore, the free cholesterol from the destroyed LCL site in intraplaque hemorrhage becoming a localized source of the cholesterol crystal. What does this mean? So whenever they see the intraplaque hemorrhage, many times the cholesterol crystal is together. That's how it looks like. And one more interesting, this is also the findings by the pathologist, the SVH graft having more frequent intraplaque hemorrhage-related necrotic core, that's just observation. But that could be the reason why such poor prognosis of the SVH graft. And we are interested in how it looks like intraplaque hemorrhage by imaging. This is a description which we presented. And when we look into the intraplaque hemorrhage by pathology, how it looks like IVUS, and we found that's low intensity area. And then we move to the OCT. So we are so interested in how it looks like the intraplaque hemorrhage by OCT. So this is a case in the consensus report from the European Journal, they show this is intraplaque hemorrhage. Corresponding segment is low intensity area without attenuation. And this is one case report showing the low intensity area without attenuation. They confirm this is intraplaque hemorrhage by dissection and coronary atherectomy. And this is a very recent case report, intraplaque hemorrhage. That's corresponding OCT picture is similar low intensity area without attenuation. That's it. So when we start looking at this type of findings, we don't have the very clear validation. But I thought, as long as we can answer something consistently by imaging, and if that is associated with the event, that makes sense. So we start looking for this type of the picture. So this is how it looks like. And the importance is, as pathologist tells us, looking for the cholesterol crystal together should be the key, meaning picking up probably correct one. So we look for the low intensity area without attenuation, having the cholesterol crystal. That is one something findings. And in our mind, probably that's indicating the intraplaque hemorrhage. We need more evidence. But when we look into those cases without, having those findings, that lesion having more lipid-rich plaque and more healed plaque, and looks like more complex, like advanced lesion. And we look into the outcome without such findings. At the lesion-specific level, having such findings has more event compared to without. At the patient level, with such findings, without, they have more event. And then adjusting model on top of the TICFR or on top of the small lumen, that seems to be associated with a future event. But I must say, this our cohort is total event is small and also 85% of a stable condition. So we don't know that's associated with the ACS event or just lesion progression. So to summarize, healed plaque is the main mechanism of the lesion progression of coronary artery disease. The presence of the healed plaque was associated with lesion progression, but not subsequent ACS event. Although OCT appearance of the intraplaque hemorrhage needs further validation, but we define low intensity area without attenuation with cholesterol crystal, which we could consistently diagnose by inter-observability that was associated future event on top of the high-risk plaque morphology, such as TICFR. Thank you.
Our next presentation by Takashi Kubo, Physiology or Imaging for Identification of Vulnerable Plaque. Physiology may miss.
Thank you very much. So non-carpet lesion-related MACE is not rare. It's very important for us. So Prospect 2 trial demonstrated the frequency of the non-carpet lesion-related MACE is approximately 8%, and during 4 years, it's twofold higher than the carpet lesion-related MACE. And ASEAN Pacific data, the Pacific Registry is a multi-center prospective study in Japan that enrolled 3,597 ACS patients, and follow-up duration was 2 years. Non-carpet vessel-related coronary event rate was 8%. So we used physiological testing to define the PCI. However, the physiology test is not perfect. This is a case ACS event arising from FFR negative non-carpet lesion. The baseline angiography demonstrated mild stenosis and distal RCA, FFR 0.92 negative. However, 6 months later, this patient had acute STEMI. Also, this is LAD, FFR negative 0.83. However, 13 months later, this patient has STEMI. Also, this is SARC, so FFR 0.85. 7 months later, the circumflex lesion was totally occluded, and this patient had a STEMI. So imaging may help to identify the vulnerable lesion, high-risk lesion in the future event. So this case baseline Angiography demonstrated intermediate region in the mid-RCA. FFO was 0.881. However, OCT demonstrated a circumferential lipid-rich plaque and a thin fibrous kappa trauma. And 10 months later, this patient had a STEMI, and the TICFR was ruptured, and it caused a thrombotic event. Also, in this case, baseline, angiography demonstrated mild stenosis in the LCX, and OCT demonstrated circumferential lipid-rich plaque, but the TCAP fibrotrauma. And a 7-month follow-up, angiography, there is no progression of the stenosis, but OCT demonstrated a fibrous cap thinning and a macrophages infiltration. And this time, negative for ischemia in myocardial perfusion scanning. And 25 months follow-up, this patient had a STEMI, and a plaque was ruptured and caused a thrombotic event. This is also a very interesting case, AMY, due to plaque erosion from fibrous plaque. So baseline, angiography demonstrated mild stenosis in distal RCA, and the stress test negative. And the OCT demonstrated fibrous plaque. And we see macrophage densities. And 8 months later, this patient had a STEMI due to erosion. But a caution is needed to interpretation of the baseline OCT image. I would like to ask Dr. Finn to give us a comment about the interpretation of this image. And next is also interesting, AM due to calcified nodule from fibrocaspic plaque. And the target is proximal RCA, and mild stenosis baseline, FFO negative is 0.81, OCT demonstrates calcium seat. But a 9 months follow-up, the lesion has caused acute MI, and OCT clearly demonstrated a calcified nodule. So we have a OCT LAS3 in a single center OCT LAS3, including 1,378 patients with 3,578 non-carpet plaques that did not induce ischemia on physiological testing, such as FFR, IFR, MPS at baseline. And we investigate the clinical outcome median follow-up period of 6 years. The non-carpet region-related ACS was 9.4%. And the OCT, this slide shows the OCT-derived TICFR and lipid-rich plaque and follow-up ACS. And non-carpet plaque characterized as both lipid-rich plaque and a TICFR were associated with 70-fold increase in subsequent ACS events during a median follow-up period of 6 years. Also, the combined study enrolled 334 DM diabetic patient with at least one coronary lesions with angiographic diameter stenosis 40 to 80% and FFR more than 0.80. And the OCT detected TICFR was associated with a 5-fold higher rate of adverse events despite the absence of ischemia at baseline. So, summary. In the physiology negative non-carpet regions, imaging determined vulnerable plaques are at increased risk for future coronary event. A clinical demonstration of the discordant impact of vulnerable plaque and ischemia on future adverse events represents a paradigm shift in risk stratification for coronary artery disease and paves the way for novel therapeutic strategies. Thank you.
And our last presentation, after which we will have discussion by S.J. Park, functionally insignificant vulnerable plaque, to treat or not to treat.
Thank you. All right, this topic actually is the same concept with Dr. Kubo's presentation, and functionally insignificant negative FFR lesions is really safe is the first question. If you look at some data, negative FFR death NMI per year actually less than 1%, and the other positive is a little bit higher. It is our registry data, FFR registry, it's cardiac death NMI. Lesion per 1 year, 0.21% cardiac death rate, a very small number. So we can say that D4 is clearly safe and good. Negative FFR means just excellent prognosis, 0.6% per year cardiac death rate, even in the presence of angiographically proven coronary artery disease. Right. Vulnerable plaque definitions by pathologic definitions, SYNCAP, fibroadenomas, ruptures, erosion, and calcific nodule, supported by many imaging almost same findings. I like this, descriptive from the, I like this descriptions. Vulnerable plaque, also known as a high risk and unstable plaque, which has higher likelihood of rupturing and causing thrombotic event, such as a heart attack or stroke. It's quite, clinical aspect. They describe this one. Advanced imaging techniques such as IVUS and OCT are also helping. He used better visualization of the plaque vulnerability. Now, what is the vulnerable plaque? SYNCAP fibrous cap, large repeat core, and inflammation and neovascularization with them is lead to the intraplaque hemorrhage, the conceptually exactly same, descriptions. Functionally, insignificant vulnerable plaque to treat or not treat, that is the main issue. So imaging define the vulnerable plaque. This is only, only data. Base rate, non-culprit and culprit lesion quite similar in acute coronary syndrome. In some conditions, higher plaque burdens, more than 70% minimal lumen, smaller, less than 4 millimeter scale, presence of a SYNCAP, clearly higher base rate during the follow-up period. And the prospect study defined vulnerable plaque, large plaque burden, SYNCAP fibroadenoma, minimal lumen area less than 4 millimeter scale. And adding the repeat core burden index by NIRS studies, unstable, stable STL elevation MI is higher, LCBI. The meaning is more than 315. The case actually cumulative base is clearly statistically higher. And so imaging defined the vulnerable plaque by OCT and IVUS plaque burden more than 70%. Presence of a SYNCAP fibroadenomas, minimal lumen area is less than 4. Repeat rich plaque, LCBI less than more than 315. So this is an example, exactly the same one, Dr. Kubo's presentation. Negative FFR, plaque ruptures, minimal lumen area is smaller than 4 millimeter scale, and the large plaque burden by OCT NIRS in the clearly LCBI is more than 300. By OCT findings, SYNCAP fibroadenoma, necrotic core more than 25%. Another case, negative FFR, SYNCAP fibroadenoma, rupture with thrombus and higher LCBI, smaller minimal lumen area, and large plaque burden. So I ask again, right? Treatment of vulnerable plaque. Current strategy of management of vulnerable plaque include lifestyle modification, medications, statin, antiplatelet therapy, and invasive procedure, for example, angioplasty, stenting, or bypass surgery, if necessary. So question one, optimal medical treatment, stabilize plaque vulnerability. So we have some, we had a study stable trials randomized with 2-to-1 and the high statin treatment and low statin treatment clearly demonstrate the person necrotic core volume changes at 1 year, and we clearly demonstrate rosuvastatin therapy can make a plaque regression and stabilization at 1 year. So conservative management, lifestyle modification, optimal medical treatment is very important. These approaches should be considered and optimized before deciding on an invasive procedure like a stenting, right? So question 2, can PCI, the stenting procedure, stabilize plaque vulnerability concern? Stent for vulnerable plaque is complex debated topics among the medical professionals. However, there are several factors to consider before deciding on stenting for vulnerable plaque. very interesting things, the risk of a procedural complication, the lack of reliable identification method, even imaging supported that it can still be challenging to accurately predict which plaques are at the high risk of causing the future event. Good questions. Treatment vulnerability conservative management is important. Just incomplete understanding of vulnerable plaques. Still, the natural history of vulnerable plaque is not yet fully understood. Some vulnerable plaques may stabilize over time, while others may progress as cause cardiovascular event. So stenting, invasive treatment for vulnerable plaque is still controversial topic. It is essential to weigh potential benefit against the risk and we have to consider. Prospect observed study is a very small number. The only data is the PCR for the vulnerable plaque and medical treatment. Clinical characteristics is same, and IVUS primary power endpoint, clearly bigger in stent group. PBS group is maintain the big minimal lumen area. However, clinical event target lesion failures, we can't define any difference. Lesion-related MACE is a little bit different, not statistical difference. Absolute number is different. Have the little bit the trend. The medical treatment is a higher progressive angina, it's a higher clinical driven revascularization. So, ultimate questions of which one would be better, PCR versus medical treatment. That is our study background to prevent PCI. And everolimus eluding stent may induce the res intima hyperplasia. PBS actually is the first one sort of part of our study included PBS so we separate 1-to-1 randomization. So overall 1,600 patients included a PCI and optimal medical treatment and negative FFR and two of our following vulnerable plaque conditions. So to determine whether PCI implantation for functionally insignificant vulnerable plaque it work or not, and so we included negative FFR and two following vulnerable plaque characteristics. And primary endpoint target vessel failure at 2 years composed of cardiovascular death, MI, target vessel revascularization or unplanned hospitalization for angina, educated to target vessel failure. Right. The typical example, Proxy negative FFR, smaller MRA, we deployed there, BBS, high pressure inflation. All right, so quite good. And we finished our patient enrollment and 2 years of follow-up, finish it, and maybe next year's ACC is you want to have some answer about the prevent study. Thank you.
We have a solid 15 minutes for questions and discussion.
I have one question to the Dr. Park. The physiologic expert said that the physiologic study may predict the plaque vulnerability. As the FFR value is the more lower, the vulnerability is accordingly increased. So just when we examine the patient, what is the cutoff value? What is this plaque is vulnerable or not?
Cutoff value absolutely 0.8 in either, right, the meaning is, even the reason has a positive FFR. If you look at in detail, inside the many factors influence the FFR itself, there are lots of vulnerable characteristics. The meaning is ruptures and plaque erosion, something like lesion length, something like that. Lots of issues actually influence the FFR. However, clinical endpoint is clear. Higher than 0.8, no treat. All right, just leave it alone. And positive FFR is treat, including the vulnerable plaque. However, issue is non-negative FFR and vulnerable plaque. By ours defined.
What I mean is the 0.8 is just the threshold for the ischemia, not the vulnerability.
What I'm talking is less than 0.8 ischemic. Among them, there are lots of vulnerable characteristics influence the FFR. If there are some vulnerable plaque characteristics getting lower FFR, however, clinical endpoint 0.8. Higher than that is just leave it alone. Lower than that, even vulnerable plaque or not, we're going to treat them. So meaning is
yes,
right.
Some plaque, as you presented in the angiogram in typical cases, the FFR value is a 0.89,
Yep.
but in cases the rupture or that is the typical appearance of the vulnerable plaque.
Right.
But even though FFR value is a 0.89,
Yes.
so 0.89 is the cutoff value predict the vulnerability.
Right, so it is not perfect one, IVUS imaging guided define the vulnerable plaque is not always perfect, right? The meaning is the cases presented negative FFR, maybe the degree of stenosis is quite low, However, there are some vulnerable plaque over there, still, very old, 30 years concept, myocardial infarction related with, almost 50%, diameter stenosis. And so small plaque may, more vulnerable for the acute coronary syndromes, right? So anyway, that is all the concept. However, it's just cases. So I gathered just negative FFR and, image defined vulnerable plaque. That is the point.
I have another question for Professor Park. Yes, you know that in China, that QFR based on the angiography is used very popular. But do you think that the QFR is the same with the FFR? Another question is if the QFR to FFR is better, helpful to comment the vulnerable plaque.
QFR is better than the FFR, you mean?
Yes, do you think that the QFR is the same with the FFR?
Anyway, I believe that one, even in the IFFR, it's a QFFR, we can replace in terms of standard value of FFR in some part. However, look at this. If you look at FFR as a determining FFR, it's a large of, plaque morphologies. We cannot, measure that one. That's many, 1,100 characteristics to be influenced FFR. So look at this QFFR, just 3 views, summation of, construction, reconstruction of a coronary vessel, and you measure those. Anyways, AI computed and machine learning something that you want to make a FFR. However, still, in fact, in real situation, we just put the wire in the real coronary arteries, and you made a indirect, calculation of FFR. Yeah, I think it's really different. Anyway, clinical point of view, we can replace that. Why not? So we can do that.
Can I ask one question to the imaging specialists like Dr. Maehara and Dr. Kubo? Okay. Yes. In the plaque can progress, but plaque can regress, right? And Dr. Kubo and Dr. Maehara's paper showing the VH TICFA is changing the future of the plaque after 1 year observation. About 75% of the TICFA can turn over to the sick fibrous or something, right? Sick fibrous. So plaque future may change. So many of the studies are focusing on the progression of the plaque or occurrence of the event. But I think we had better focusing on the which plaque can regress by the intensive medical treatment, because we can now expecting a lot to the optical medical therapy. Do you have some data or comment about that?
Actually, if I may answer,
Yeah.
we have published that in JAHA.
Uh-huh.
ACS is the strongest predictor for statin responsiveness.
I mean,
It all goes along the same line. ACS, higher level of inflammation, statin is anti-inflammatory therapy, so it does respond better. The poorest predictor is CKD.
there are a couple of things. First of all, as you mentioned, TICVAs can stabilize, but TICVAs can also appear out of what used to look like stable plaques. So this is a very dynamic process. TICVAs can rupture and rupture silently and heal without causing events. We are very good at predicting stable disease. We are not good at predicting instability in the future. If you look at the positive predictive value of all of these studies, it is extraordinarily low. The negative predictive value is extraordinarily high. And that applies to imaging, physiology, whatever. The question?
This question is to Dr. Ik, Jang, and maybe to Dr. Akasaka too. So you have a patient with a prox LAD 40% lesion, and the default strategy right now is to put them on high-dose statins, lower the LDL, risk factor modification, and that usual stuff. Is there anything on imaging that would change that? I mean, you've shown very nicely that what the features of vulnerable plaque are. Is the reverse also true? Is there something on the OCT imaging that might make you say, well, this patient has got stable disease and we don't need to be that aggressive? And
My answer is absolutely nothing.
okay.
I'd like to make a question to Akiko Mahara. One of the acute coronary syndrome problems is Inoka and Minoka. Could you please share with us your comments about the findings of OCT?
I think that if you want to diagnose Minoka, I think the OCT is the best, and we just explained yesterday. But I think the underlying pathology is slightly different compared to the regular stenotic MI patient. We look into, and actually, out of 145 patients, we diagnose some culprit by OCT in the Minoka patient is only half. And about those, the plaque rupture is, truly plaque rupture is only like 8%. And plaque erosion is only like 4%. It's very rare. I mean, typical plaque rupture or erosion in the Minoka patient is very rare. And the majority is actually intraplaque hemorrhage. I think about like 30% that's intraplaque hemorrhage. And that's because of the, when we look at the super old paper, there is a rupture, but that's already sealed. And on the top is already like thrombus. And you can see only the plaque, intraplaque hemorrhage inside of the plaque. That's, I think, we see more often in the Minoka patient compared to the MI underlying plaque. So I think like because of the, they are mild troponin positive, so they have a little bit event in terms of the pathophysiology. So I would say overall it's similar, but I think like the pattern is slightly different.
What I don't understand about Minoka is why do they get an infarct? I understand that there's underlying OCT pathology.
So, excuse me, Minoka is a heterogeneous entity.
Agreed.
So it is not that straightforward. There is a Minoka with atherosclerotic plaque and
Agreed.
without.
Agreed.
Yeah.
But
Yeah,
why do they get an
I
infarction?
think like if there is
Supply
a,
problem.
go ahead.
But if you look at the angiograms and you look at the OCT.
Oh, the small one is, I think we have seen few cases, small plaque angiographically not evident, disrupted if you look at it with OCT, small plaque with central rupture.
I see.
I think when we look into the OCT, intraplaque hemorrhage is actually sometimes, in some point, it's rupture. So some point they rupture, and the tiny thrombus we see by OCT. So that's going to the distal, causing the
So you may think it's embolic.
Yeah.
Embolic, I accept.
Yeah.
Okay.
I have a question to Aloke. We discussed this. So, whenever we start new project, we do thorough pathology literature review. Calcified nodule is the only entity reported in pathology studies your mom, you, and why is that? In vivo, you're part of the study, superficial calcific plate or, is the most frequent type, which has never been described in pathology.
Yeah, and in fact, his paper says that it's rare.
Yeah. Is it, so, as I said during my talk, a lot of features are similar to plaque erosion. So they cause ACS, but not bad enough to kill people? Is that the reason?
Well, that's a good question. I don't know. Please speak, Mike. Everybody want to listen to your answer.
Yeah.
I don't have a good answer for you. I think that the fissure is a very distinct entity where, the plaque essentially dissects via the collagen, where the collagen forms and comes together. There can be a tracking, a dissection into the plaque center where bleeding occurs. So that's a different entity, but I mean, I don't have a good answer for why. I'm curious as to what you showed with the calcified surface calcium causing thrombus.
There are two types,
yeah.
Right? Superficial calcific.
We haven't seen it, and I don't know why. I mean, clearly, are we missing something? I don't know. That's not an entity we've described. So I don't know if that's But remember, we are biased by our what we get.
Yeah.
We don't. That's why I think the OCT studies are so important, because it's hard to confirm how often these things happen in non-selected cases, because we're only getting the selected cases.
Okay, so our time has pretty much run out. It's actually been a great session with good discussion. I thank the audience, my co-chair, the panelists, and the speakers. All right, two more things to do.